Department of Neurology Backgrounds. My name is Sunil Patel. I'm also a little bit of a guest here. You don't know me, so I won't introduce myself. It's my great pleasure to have our speaker give a talk, but I'd like to give a little bit of background. What's a neurosurgeon interested in EDS and mast cell disorders? Because I sort of left that brainy stuff way back in the medical school. EDS was, I remember in med school in the last century when I went through medical school, in a small chapter in a book that I ignored. Orthostatic syndrome was a hereditary collagen disorder, and I said, whatever. And I just memorized it so I could answer the board questions on collagen disorders and EDS. I said, yep. Fast forward, about a decade ago, I started seeing patients with EDS, and it turned out that this is not just a collagen disorder. These patients have a multitude of different organ problems and systemic issues. And I've been, personally being a neurosurgeon, I get to see all the neurologic and spinal disorders, but then they come in with a horde of other issues. From dystonias, you all know dystonias, to dysautonomias, to mast cell disorders of a variety of kinds. So it's my great pleasure to introduce somebody I just met 10 minutes ago, but I had heard about her about 3-4 years ago. Dr. Maitland is a internist who's done very, very good work and very focused work on mast cell disorders and dysautonomia. So I'm personally looking forward to this because I never spend an hour reading a book, but I'm hoping in the next hour she's going to teach
Reader's Digest version.
Reader's Digest version. So welcome to the Low Country, MUSC, and I look forward to your talk.
Thank you for such a gracious invitation, and good morning. Hello. So I'm going to have the pleasure of taking you on the journey that happened to me. If any of you watched The Matrix and, Nemo had the choice of taking the red pill or the blue pill. Well, one of the patients I had met almost 10 years ago forced me to take the blue pill to look at a new reality regarding everything that I had been taught up to this point. And this includes getting a BS at Yale in biology, MD, PhD at University of Pennsylvania, internal medicine and allergy immunology training at Brigham and Women's Hospital. Mast cells was maybe 1 or 2 lectures first year of medical school. But this was one of the first cells that was identified in the mid-1800s. And we really didn't know what this cell did until, I would say, 1988, when they identified serum IgE that binds to mast cells. And now they're like, okay, now we figured out how allergic reactions work. So we need to kind of go back in time to talk about mast cells and how they interact with nerves within the connective tissue. And that's why we see this kind of like trifecta of connective tissue disorders in the setting of immune dysregulation and impacting the nerves, which I think the nerves are essentially collateral damage in the process. So just some housekeeping. I am on the Speakers Bureau for Genentech Novartis as well as Sanofi Regeneron. I will not be talking about any of those products. And this is a picture of one of my patient's sisters who, again, suffering from recurrent anaphylaxis, connective tissue disorders, and she wanted to raise money because it was really difficult to get funding because nobody believed in any of these conditions. So let's talk a little bit about one of the more common manifestations of dysautonomia, and that's postural orthostatic tachycardia syndrome. And I, as an allergy immunology specialist, are going to retreat into my little corner very quickly and just talk about the fact that we really don't know how to diagnose these patients very well. They look fine, and they have a tendency to acclimate down to what their bodies let them do. So if they get dizzy standing up too quickly, you get up slowly. If you get tired, you quit the sports that you played in. So people will acclimate down to what their bodies let them do. But the official definition of it is you have somebody who has an inability to kind of increase their intravascular volume so that the brains and the kidneys are happy. And then typically what happens is the heart takes up the deficit, and now you start pumping even further. And interestingly enough, my daughter, who has this, was discovered after 7 years and being evaluated at least 4 major academic medical centers. It was her sitting at the table, leaning on her hand, and I had been seeing patients with EDS for close to 5 years. And I'm like, you gotta be kidding. So we're not taught, and by the way, one of the terms that they use for these patients are hiding in plain sight. So unless you bend these people, stand them up, even looking at cervical spine instability, you can't just necessarily evaluate it with a prone MRI. You got to stand them up and have them flex their neck, and then take the picture to see whether or not there's any displacement. So these are some of the symptoms that are associated with having postural orthostatic tachycardia syndrome. So you have CNS effects, you have peripheral nerve effects, gastrointestinal distress, skin symptoms, bladder symptoms. Anywhere you have nerves, you can have a problem. Typically, these are females, but we do see these in males as well. And on average, the data out of Jeff Boris's former clinic at Children's Hospital of Philadelphia, children will suffer for 3 to 4 years before they get an actual diagnosis. So why is an allergy immunology specialist talking about POTS? Everything in the body is connected, and this is just showing you the relationship between the lymphatic system, the cardiovascular system, and the nervous system as well. Mast cells and nerves coexist, and I would say a few years ago I started getting referrals not only from neurologists but neurosurgeons as well, and I would say about 10% of the patients I see right now are from neurosurgery, because they'll get fused at the atlas to C2, and then all of a sudden they start slipping below where they've been fused. I have one young lady who actually has had 3 cervical fusions starting from C1 all the way down to the end of the thoracic spine. And then the patients are also complaining about symptoms: flushing, interstitial cystitis, irritable bowel syndrome, headache disorders, pruritus. And they would come to me and ask, this must be an allergy. And so I would allergy test them, and they'd be completely negative compared to what this little boy is undergoing. And that's the reason for that is because, mast cells have more receptors than the IgE receptor, Fc epsilon Ig receptor. They have toll-like receptors, they have cortisol receptors, they have estrogen receptors. All of those sensors are needed to evaluate the surrounding microenvironment so that they can figure out how to meet the needs of the community of cells they've been assigned to. And this is kind of give you an idea. Let's see if I can do this properly. Okay, never mind. So you can see that the mast cells are centrally located. They are situated right below the surface area of the epithelium. And they interact with the nerves, they interact with the blood vessels, and the surrounding connective tissue. So think about if you have some type of a trauma. You end up with redness, swelling. That's the mast cell releasing chemicals, talking to the nerves to say, itch or pain. You need to pull your hand away from that fire or away from that itchy plant. And then also call for help, whether you're calling in proteins like complement, immunoglobulins, or cells. And I've had the pleasure, I shared last night that one of my first lectures in medical school was, each and every one of you need to be on the other side of the bedpan at least once, and some of you SOBs twice. And this was University of Pennsylvania, and I'm looking around like, there are SOBs in this class? Sorry. But nonetheless, I developed cold-induced urticaria as I was doing research. My PhD was actually on early signaling defects in individuals that had HIV, and I had to work in the cold room in the P3 facility, and I developed cold-induced urticaria. And then that morphed into delayed pressure urticaria, and then that morphed into dermatographism. And basically, nothing was telling my body to tell those mast cells to stand down. And so we have individuals that have plenty of non-allergic triggers which reveal the communication between mast cells and nerve fibers within the connective tissue in certain individuals. So if you look at the symptoms that are associated with POTS, you can see all those symptoms actually overlap with individuals that reportedly have been diagnosed with mast cell activation syndrome. Again, reflecting the crosstalk between mast cells and nerve fibers, which makes sense. Unfortunately, medicine is very siloed right now. We have a tendency, I remember the first neurosurgery meeting I went to, and I think I was the only internist in the room. I'm like, one person is just not like the others here. But it's a needed crosstalk. When you're talking about asthma or headache disorders or irritable bowel syndrome, it's not just the epithelium, it's not just the nerves, it's not just the immune system. All of those organ systems are talking to each other, negotiating the environment that they're seeing, whether you're breathing it in, whether or not you're ingesting it, or it's going through your skin. You have to figure out what's supposed to stay and what's supposed to go out. And if you have less reserve, you're going to start letting things in that can actually cause more tissue damage, and that gets perpetuated forward. So little mast cell history. Again, these cells were identified by two German pathologists in the late 1800s. They lit up these cells with the dyes that were used to cause really royal colors in the German monarchies, and these cells lit up in every single organ system, and they were described as Manzellen, meaning fat cells or well-nourished cells. And I guess it kind of likened to, you know, what it was like to be a landowner and you have this one house that's feeding off the land. But that's not the case here. The cells, that one cell is responsible for surveillance of that surrounding community of connective tissue and structures, and has the ability of secreting enzymes like tryptase and chymase. And Tachycardia, who's up in Boston, who's doing mast cell research and ties mast cell research into autism, has identified that the tryptase is almost like a meat tenderizer. It really loosens up the connective tissue, which makes sense. So if you get stung and you need to let stuff in, you got to make room. Think about when you have a code that's called, right? Everybody rushes in, and then you need to make a decision on who needs to stay and who needs to go. This is kind of the job of the mast cell. It is your first responder. But that's not what I was taught. I was taught that if you have any one of these symptoms, you need to do allergy testing. And I'm looking for allergen-specific IgE, whether you're talking airborne, foods, or medications. And then basically in the 9 minutes that were left during an office visit, typically it's like, okay, it's not allergic. Here's some antihistamines, I wish you well. We have to take a little bit further than that, and you have to look at it as an opportunity to pursue a higher truth. We have a tendency, because of the systems that we work in, to kind of stop halfway. And just saying that it's not allergic is not enough to try to figure out what might be going on in this patient population and understand that hypersensitivity disorders is an epidemic, and I'll show you why. So we've been essentially taught that you have a serum IgE that's produced by B cells under the instruction of T cells, but there's a lot of history before that happens. What happens is there's been some type of injury to the tissue that upregulates the antigen-presenting cells, including mast cells and dendritic cells. Then those instruct the T cells and B cells to make the antibody that then sits on the mast cells that acts as surveillance. We have a tendency to just focus on the adaptive immune system when we're looking for autoantibodies or allergen-specific IgE. But really, it is the innate immune system that instructs the adaptive immune system what kind of immune response you need to set up. Mast cells have been researched since the early 1900s. Matter of fact, the first molecule that was identified in mast cells was not histamine, it was actually heparin. And I had the pleasure of taking care of a patient who had sensitivity to nonsteroidal anti-inflammatory agents. His primary care told he had a reaction, had flushing to naproxen, told him never to take naproxen again, didn't warn him about ibuprofen. He took 2 doses, he took ibuprofen for his headache. He quickly went into disseminated intravascular coagulation. So he started bleeding, he was kicking out heparin, and then he started consuming his platelets, so he also clicked out platelet activating factor. He's lucky he survived from that one episode. And in a New England Journal of Medicine review article, it says regarding anaphylaxis that DIC is a risk factor. So let's talk a little bit about where mast cells come from and what their job is supposed to do. They start in the bone marrow as progenitor cells. Unlike eosinophils, basophils, monocytes, lymphocytes, you cannot see these in a complete blood cell count with a differential. They're born in the tissue, they end up serving in the tissue, and in every single organ system. They have a tendency to be situated right next to the blood vessels and the nerve fibers so they can help coordinate responses. There are lots of different receptors that are found on mast cells, and as a matter of fact, mast cells are actually found in organisms other than mammals, which means there's other receptors other than T cells and B cells that will instruct the mast cells on what it needs to do. We found toll-like receptors, which were really identified in fruit flies. We have complement receptors, estrogen receptors, progesterone receptors, cortisol-releasing hormone So all of these things have a tendency to tell the mast cell, this is what you should secrete or not secrete. And by the way, there are two different types of degranulation patterns. So if you've heard about red man syndrome with vancomycin, that is actually through the MURG receptor, and that causes a degranulation process like a hand grenade going off. But if you go through the immunoglobulin receptors, you actually cause the granules to be released intact, and then they migrate to other parts of the body and then explode. So this is how the body is able to communicate, I have a problem here, you need to rev up your defenses here, because we're not sure whether or not there's going to be a bigger offense coming. So in a lot of ways, mast cells are kind of like your police officer who's going around your neighborhood, has a set of mugshots, has a site of what are usual suspects, and essentially having those receptors engaged, like someone who has a positive ANA of a 1 to 40 or 1 to 80, doesn't necessarily mean that the mast cells or the effector cells are going to go off. There has to be a first signal. It's kind of, again, if I think about what life is like right now in Grand Central, with all that activity, there are a lot of individuals that are profiled because that's what mast cells do. But the profiling doesn't necessarily mean that you can engage that person and arrest them. So there has to be some type of a warning signal, some type of danger that will cause the mast cells to uptick their activity. And what we see happening at the border, because at the border, your skin, your gut, your respiratory tract, you have about 75 square feet of territory in adults that need to be guarded 24/7. The purpose of the immune system, the innate immune system, is to provide or be a gracious host and allow organisms like good bacteria who will provide with not only nutrients such as certain vitamins that we cannot produce, but also provide protection. Kind of like having, what's happening in certain parts of the country where you align yourself with the local villagers who are going to be more aligned to your philosophies, and also to identify individuals that are dangerous. Same thing that happens with the surface area and the immune system, including the mast cells. And then also, depending on what kind of breach of the border, the tissue and the mast cells will start upregulating certain activities in order to contain the danger and also coordinate tissue repair. So basically, the purpose of mast cells in the connective tissue before allergic inflammation ever became an issue is surveillance, a genetically programmed response depending on what type of insult it's seeing. For instance, if you're stung by a stinging insect, you have swelling. You don't necessarily start recruiting in eosinophils and lymphocytes. If you are having a breach that's done by some type of virulent bacteria, you're going to call in neutrophils. If your body is seeing seeing parasites either through the toll-like receptors or through IgE, you're going to call in eosinophils, which are essentially the SWAT team. And when it comes to the cross communication between mast cells and nerves, there are plenty of chemicals that go in between the mast cells and the nerves to raise up the alarm, and then once the danger is quelled, to calm down the inflammation as well. So we're very familiar with histamine, but substance P gets released, nerve growth factor gets released, interleukins get released, and all of these can change and modify the interactions that are going in between the mast cell and the nerve fiber as well. So there is some type of a danger signal. Typically, it is a product that's released by healthy cells showing that they've been injured. That includes DNA, RNA. Sometimes it's heat shock proteins, interferons, and also engagement of the CD4 ligand. All of this is a danger signal, uptaking the activity in mast cells. Mast cells will start secreting chemicals to call in help, depending on what help it thinks it needs. And then again, after the danger is cleared, the purpose of the mast cells is to talk to macrophages as well as the surrounding fibroblasts to help with the healing. So when you see in someone who has a connective tissue disorder, you not only might even see unusual infections or inflammation that's not necessarily due to infection, they can also have abnormal healing, such as fibroids. So just to kind of sum up, the purpose of the mast cells is to recognize tissue danger through reconnaissance, organize a response, and then organize the repair response as well. And this can happen from infectious agents. Basically, it's chemicals, either naturally occurring or manufactured, as well as sensation through the nerves of changes in the environment, physical changes within the environment. We actually have 2 patients in the practice who actually have had anaphylaxis to vibration. So they found that out when they were jogging on a treadmill. the hard way. So, and if you really want to see what the mast cells are capable of doing, I would encourage you, when you have a few minutes, to kind of YouTube honey badgers. Honey badgers are vicious little things, but they have an attitude. And this one particular film, the honey badger goes up to one of the most venomous snakes in Africa, actually takes the mouse out of the snake's mouth, eats it, and then goes after the snake, and actually catches it, kills it, starts to take the fangs out so it won't get stabbed by the venom, and then you see his mouth starts to swell, and then he starts to lie on his back. I'm like, oh, he's a goner. They kept filming. He recovered in about 20 minutes. So chymase and tryptase have the ability to detoxify venom. So these mast cells really are your first responders. So unfortunately, the world has kind of changed. I mean, honey badgers are still in that environment where your mast cells are engaged with usual suspects that our ancestors have been dealing for a long time. Our world isn't. We have, within the past, I would say, 20 years, have completely changed how we live, how we breathe, how we sleep. You know, I grew up in the Bronx, and they were still delivering milk in bottles. You still got meat that was locally raised. If you were cold, you put on a sweater. You didn't go to the thermostat because oil was expensive. So our bodies, we no longer train our bodies. We change our environment because we're creatures of comfort. And by doing that, we reduce our reserve to deal with challenges that come forward. So I use this little clip art from the 80s, but plastic is a huge problem. I would encourage you to see that if you look at plastic bottles right now, they say this is a BPE-free bottle. BPE is actually, looks like an estrogen to your cells, and that will change how your mast cells perform. And you can actually end up being sensitized even more simply because you have a more female-like phenomena happening within the tissue itself. So, and what's really interesting, I just did this morning, talk about exposures. So the hotel I'm staying in says the water in Charleston is safe. I'm like, okay, is there a reason why you have to say that? I'm like, okay, so is this Flint? What are you talking about? But again, how much control do you have over the air that you breathe or the water that you drink? Or even Johnson & Johnson just announced that they're taking 50% of the products that are in their baby shampoo. And in the 1970s, the FDA approved preservatives to be in baby food. So food can sit on the shelf for up to a year. And those chemicals our bodies don't like. So within the past, I would say 20 years, we now have an epidemic of hypersensitivity reactions. And the concern has mostly been with children, but we're now seeing in adults, and now that I have my AARP card, I would have to say seniors as well. But what's really interesting about hypersensitivity disorders, there are a lot of neurocognitive issues, neuropsychiatric issues that are associated with ongoing inflammation. Even in the most common disorder, rhinitis, 'tis the season, right? Whether you're clearing your throat, pardon my raspiness, you're susceptible to migraine headaches in the setting of inflammation. Actually, as one of the attendees last night came, he was having anaphylaxis. He's been treated for anaphylaxis twice within the past 2 weeks. And I'm like, what has changed? And he's like, nothing. And I'm like, okay, lean forward. And he's like, yeah, I have a little pressure in my face. He had a sinus infection. His sinus infection actually opened the door for him having hypersensitivity reactions. So it's really not just about allergies. You know, when you have ongoing inflammation in any organ system that's inappropriate, you're paying the price. First of all, you're taking away resources from other places in your body, like housekeeping maintenance, in order to fight a fight that doesn't need to happen go on. And so I gave a lecture a few years ago at the National Medical Association talking about rhinosinusitis because a lot of people say, it's just allergies. But this is the number one reason that people can't go to work, lose time at school, or can't focus. And it's also associated with sleep disorders, and sleep disorders is associated with lots of different types of neuropsychiatric issues. You also have increased risk for developing lower airway inflammation, migraine headaches, and you can't get other diseases under better control, including diabetes and hypertension. So this really crossovers into a lot of things other than just your nose misbehaving. So let's talk about how to define mast cell activation syndrome as opposed to saying whether you have allergy-driven mast cells causing problems or not. And so, interestingly enough, it was first thought that mast cells can misbehave outside of allergy inflammation or mastocytosis, which is the most well-known clonal mast cell disorder, over 20 years ago. This article that I showed you that is now donning our Journal of Allergy and Clinical Immunology just came out this past April. So and unfortunately, this follows suit with most observations. Dr. Lenfant, who was the head of NIH regarding drug discovery, cites that it takes about 17 years for practitioners to learn new tricks after something's been identified. And this was true for fibromyalgia 20 years ago, and now it's true for mast cell disorders. But mast cell activation is more than mastocytosis. And I'd like to point out mast cells in that previous picture you saw was just a single round cell sitting around connective tissue. If your patients have undergone endoscopies or colonoscopies, it would be important to go back and tell the pathologist to stain for mast cells, because if you don't use the right stains, you won't see them. And what you want to look for possible mast cell activation disorders, whether it's a clonal or a non-clonal disorder, are the mast cells clustered, which is happening here, or are they spindle-shaped? And then you can do other stains to see whether or not they're chronically activated or not, because a chronically activated mast cell is like a police officer who has his guns drawn at all times. Something's bad's going to happen if it's not reholstered. Also, it's not just mast cell, it's not just allergic-driven inflammation as well. So my blue pill was this little boy named Shawn, and this was a letter that his mom wrote when I was trying to write for a grant that those Girls on the Run supported. And she basically said that her son was down to 6 foods. He had anaphylaxis, he had asthma, and you can see this is what he was like when he was first born, and the lower picture is what he was doing in my office when I first met him. He had already seen 10 allergists, 4 orthopedists, 4 gastroenterologists, 3 geneticists, 2 nutritionists, 2 rheumatologists, 2 endocrinologists, 2 physical therapists, a cardiologist, a neurologist, and a pulmonologist, all to no avail. So, Dr. Patel, when you were talking about that, these patients are coming with lots of different issues, if you have mast cells misbehaving in every single organ system, you're going to have manifestations of it. And unfortunately, this is much more complicated than one single specialty, and the primary care are completely unprepared to deal with this because of the complexity of the disorders, and also the availability of testing to identify individuals that are susceptible. So he'd been allergy tested, so I'm allergist number 11. I'm not going to do that again. So he has no evidence of allergic inflammation. Matter of fact, his IgE was a total of 10. He had no evidence of mastocytosis. There is the ability to test for mastocytosis in the blood. If it's positive, it's helpful. If it's negative, it's not. You can actually look for c-KIT mutation in premature or maturing mast cells that are circulating in the blood. And so, but this is my reintroduction to Ehlers-Danlos. Yes, my one board question like 7 years ago. He sat in a W the entire time. And so this is what it's meant by looking at your patient, because if you're looking at the computer all the time, you're going to miss it. It's amazing what these people are adjusted to do. And since I'm as stiff as a board, I tell them to grab my ear because I can't move it. As a matter of fact, when my grandmother, who is from North Carolina, grabbed my ear, it hurt. These kids can do this, they can bend their fingers all the way back. I mean, matter of fact, the screening questionnaire that I use for Ehlers-Danlos is, can you do funny tricks? One of my patients is 74 years old. He's had 3 operations on his left knee, 3 operations on his right knee, and I ask him, are you flexible? He's like, funny you ask me that. The physical therapist is really impressed that I can still bring my leg behind my ear. I'm like, all right. So I won't tell you about the scars that are on his knees. Again, characteristic. And so if you're doing surgery and that wound isn't healing properly, I'd be concerned about a connective tissue disorder as well. So basically, I had to kind of, I took the time to listen, right? And instead of looking for names, I try to think about what could do this in a child where the allergy testing is negative. And the best model we have for allergy immunology specialists is how many different ways can you have hives? So you have allergic triggers and non-allergic triggers, and this is a whole list over there to show you there's lots of different ways that the mast cells can get a little pissed off. Oops, sorry. And just to kind of give you an idea regarding all the different types of exposures that we continue to have, you can have lots of different types of inflammation recruited in, whether it's serologic, meaning I can find an antibody, whether you're talking an autoantibody or an allergen-specific IgE, or an abnormal T cell or B cell population, or again, these physical triggers. And here's the thing, you have individuals, I have to carry an EpiPen. Not because I have peanut allergy, and matter of fact, my son has peanut allergy, my husband has fish allergy, so every time I'm away from the home, I'm like, I'll have the pistachio-encrusted tilapia, so I don't kill anybody when I go back home. But because of the cold-induced urticaria, and I actually found out the hard way because I went to a reunion, I went to the dance floor, it was by the beach, and I started to hive getting off the dance floor. So just my body not being able to adjust appropriately, pivoting to the change in the external environment, I started hiving. And I'm like, I'm fine. It's amazing denial. So I really had to start thinking about and had to go back and learn about mast cells because I spent most of my life, I've been studying the immune system before HIV got a name. I worked at Rockefeller University, I worked at Columbia Presbyterian with the gentleman who actually identified CD4 as one of the receptors for HIV. And this is not about T cells. You know, all the days I always just think regulatory T cells were God. No. Mast cells, actually MC reg in my opinion. And you can see these are all the chemicals that mast cells can elucidate depending on how it's engaged. And work by Dr. Theoharides has actually identified in certain parts of the brain, mast cells will not only proliferate, but they also remain chronically activated, especially near the brainstem. So mast cell activation syndrome is simply defined as, do you have signs or symptoms reoccurring in at least 2 organ systems? Do you respond to medications that cause the mast cells to quiet down? Diphenhydramine, loratadine, Zantac, all count. And then, this is the hardest part. What data do you have to support? So God forbid you actually get a really good story, and then you look for the data to try to reinforce your hypothesis. To give you an idea of the signs and symptoms that are associated with mast cell disorders, basically, people will go to the doctor if it's their skin or their GI tract, but interestingly enough, not the easiest thing to measure if you're not a psychiatrist, neuropsychiatric disorders in both populations. Then, when it comes to looking for markers, everybody says serum tryptase is normal. We don't know what a normal serum tryptase is. And honestly, if you want to identify somebody who has mast cell activation syndrome, you have to treat it like you're looking at somebody who's having an acute cardiovascular event. It's serial blood tests that will help you identify whether or not somebody's having a mast cell disorder or not. You can also look for prostaglandin metabolites, but you know, it's not the easiest thing to collect a 24-hour urine and keep it cold and then tell the technician at the lab, put the cigarette down, please put this back in the refrigerator very quickly. You know, there's a lot of hiccups there. But honestly, the best way to try to identify is actually look at the tissue. And there are 2 neurosurgery groups that are now looking at biopsies for individuals who are undergoing tethered cord surgery. And what's really interesting, in the individuals that end up having retethering of their cord, the mast cells look really unusual. So, and then lastly, there's lots of different medications that are used to quiet mast cells down. You can either target the individual mediators or the mast cells themselves. The ones that we use for the diagnosis are histamine blockers and an old-fashioned psychiatric medication. So one of the first medications used for mood disorders were tricyclic agents. Then the SSRIs came around, so everybody dropped the tricyclic agents and basically focused on giving Prozac and Zoloft. Interestingly enough, allergists use it for chronic urticaria, gastroenterologists use it for IBS, and neurologists use it for headache and pain syndromes. So there's something to be said about some of these older medications. So basically, this is a summary. Symptoms in 2 different organ systems. Do you get better with histamine blockers? And again, what test results do you have? So once you get the diagnosis that your mast cells are misbehaving, you need to figure out why. And you know, I'm a simple kind of gal. You got something broken within the mast cells, or something is forcing the mast cells to break bad. So mastocytosis and monoclonal mast cell activation syndrome, which is kind of like mastocytosis junior, is less than 200,000 cases worldwide. Most of these mast cells are misbehaving because they're responding to triggers in the environment that they're protecting. So allergic inflammation, we'll see it. We'll see it in, and I'll go through some of the patients that we're seeing, physical urticarias like I have. You can actually make an antibody against your mast cell, just like you can do your thyroid or your liver. And then we have an unusual patient population, which is the first explanation we may have for a genetic basis for hypermobile type Ehlers-Danlos syndrome. So back in 2014, a group at NIH identified families, so it's an autosomal dominant inherited pattern, that have an elevated serum tryptase level. And that elevated serum tryptase level is associated with duplication or triplication of the mast cells of the alpha tryptase gene. So these individuals end up with a trifecta, which sounds familiar. Ehlers-Danlos syndrome, mast cell activation syndrome, and dysautonomia. So this is the testing that I typically do to try to understand why your mast cells are misbehaving, including revisiting allergy testing. I don't necessarily order it, I just look and see whether or not it's positive or not. We go back and look at the endoscopies, colonoscopies, staining for mast cells. I have to tell you, the biggest factor I've identified in individuals that are not allergic, we've identified 15 patients that have idiopathic CD4 lymphocytopenia, and they weren't showing up with recurrent infections, they were showing up with hypersensitivity disorders. One gentleman, as a matter of fact, I sent him to NIH to evaluate for another mutation called DOC8, where you knock out not only your T cells, but your B cells as well. They felt it wasn't DOC8, but possibly it could lead to the identification of another gene product that caused that to happen. We see whether or not there's any autoantibodies, and then we screen. One of the attendees last night asked me, so do people know that they have EDS when they come see you? I'm like, no, because they're focused on the hives. They're not focused on the fact that they're bendy. Matter of fact, they don't even think they're hypermobile. And I have to point it out to them. So you also need to be careful that there are a lot of other conditions, because mast cells engage other cell types. There are other conditions that can be the primary driver of people's illnesses and not necessarily mast cell dysfunction. And so this is a list. So it's really important that you apply solid diagnostic criteria. It's important because a lot of these patients are told that there's nothing wrong with them, or you look fine. I had a patient, a 21-year-old, who spoke 3 languages and was an honor student at LIJ, died on the table as she was getting a G-tube replaced from serotonin syndrome. So preventing adverse reactions in the operating room. If you identify these individuals that have a connective tissue disorder, they're going to have mast cell dysfunction. So there's anesthesia that they might not tolerate. They're not going to do very well with morphine. They're at a greater risk for certain types of infections. So it's important to kind of diagnose these individuals ahead of time to prevent worsening of their comorbid disorders. So this is a view from my room, my office in Tarrytown. I often have to look out saying, God, why me? But we have a collaborative effort in my office with an otolaryngologist, so we can get some tissue in the nose and sinuses and look for mast cell dysfunction there. Skin is also an easy place to try to evaluate that. The physician assistant has been working with me for about 10 years. He's a dermatologist by training, so he's extremely helpful in trying to identify what's going on as well. And we also have a clinical psychosocial worker, because it's not easy being sick for so long and then being told nothing's wrong with you. So, as I did last night, I'm going to do it again, and it's important. This is sometimes a bit of a long talk, so I was told I should tell a dirty joke. So people with EDS consider themselves zebras. This is a zebra rolling in the mud. It's not a zebra rolling in the mud. 2 zebras rolling in the mud. Actually, do you know what a group of zebras are called? a dazzle. So you have these zebras dazzling in the mud. There, that's my dirty picture. Okay, so anyway, so I had decided after meeting Shawn, I had to do some intensive research, and all my training really didn't give me a clue, so I went to Google, and the first thing I came up with is these comments by Dr. Symes, who was basically just sharing some ideas about what was going on with the patients that he was seeing. You ever see these patients like tear their cruciates in the springtime? Do you see them having autoimmune disorders, especially early on in life? Do they have neuropathic issues or develop cancers early? And I'm like, that sounds familiar. So this is what he was seeing in his patients. They were having back problems, they were having gastric motility issues, they were having weakened supportive ligaments all over, food intolerances that were not explained by allergy testing. And here's the thing, Dr. Symes is a veterinarian. And interestingly enough, there are veterinarians who specialize in neurological disorders that are identifying similar issues in dogs that we're seeing in humans as well. So these are the dogs that are more at risk for having these hypersensitivity disorders, the ligament issues, and also the neuropathic issues as well. And will give us some more insight, might be what's going on with us as well. There have been allergists that have identified individuals that are increased risk for hypersensitivity reactions. This is one of the patients that was in my office, and you can see when she did allergy testing, this is as far as my arm goes. So it's amazing what people get used to. Also, this was a paper that came out of Russia, Siberia, and interesting, I don't know why they would be asking this question about people, and they call it connective tissue dysplasia. And what they did was they actually just looked at the mast cells in individuals who underwent elective surgery, cosmetic surgery, and they screened them based on whether or not they fit the criteria through the Beighton of a connective tissue dysplasia or not. And what they showed was and understand, lots of different mast cells, all mast cells have tryptase, not all mast cells have chymase. And what was really interesting in these patients, the ones that had no evidence of a connective tissue disorder, their chymase representation was the same as identified in other studies. But if they had a connective tissue disorder, they had much more chymase positive cells. And chymase is an interesting thing. It can actually modify transforming growth factor beta, which can cause connective tissue issues. So we're all starting to connect the dots with these patients based on these observations between the connective tissue, the mast cells, and then altering the connective tissue, you're going to impact the peripheral nervous system as well. So, and then this is a comment from Mark Castori saying that connective tissue disorders is more than just a joint problem. So you have pain syndromes, gastric motility issues, chronic headaches, decisions, but he couldn't understand. He said there's immune dysregulation, and this is 2012, when the mast cell activation syndrome was only coined in 2010, but I have to say right now, it looks like it is the mast cell that is the center of the immune dysregulation in these patients with connective tissue disorders. This is the type of screening that we do. You look to see whether or not they have the ability to bend their hands. This one 2-year-old, her finger went like this, and this when she was pressing the keyboard. So it's how they operate, and then these individuals, because they're stressing the ligaments, they end up with proprioceptive issues, and then the proprioception issues leads to them having trauma, and then the trauma leads to more mast cell dysfunction. So it's a vicious cycle that just does not get interrupted. So we did a study that the little girls helped me do, along with the help of 2 volunteers. And we basically just did a retrospective analysis on patients that had a connective tissue disorder to see whether or not they fit the criteria of mast cell activation syndrome. And you can see here, all of them had episodic recurrent symptoms. They all improved with mast cell targeted medications. You can see that tryptase was like non-existent, and we repeated it and didn't go up. But again, going back to that Siberian study, it was chymase that seemed to be a problem, not tryptase. So, and this is essentially saying, again, this is not allergic inflammation. It's going through another receptor and it's kicking out something other than tryptase that's causing the problems. So we started screening individuals for mast cell dysfunction, connective tissue disorders, and the one thing that really popped up in these patient populations, and we screened close to 600 people right now, we're finding individuals that have immune deficiencies. And here's the thing about connective tissue. Your B cells are made on connective tissue. Your T cells are educated by the connective tissue. So and there was an early observation in the 1960s that individuals that had connective tissue disorders, whether it's Ehlers-Danlos or Marfan's, had IgG subclass 1 and IgG subclass 3 deficiencies. So there's something breaking down in the production of your sensors. And then your mast cells still have receptors that might be able to recognize something and get stressed and then start responding to it inappropriately. So this is just showing you that the warning signs that I just showed you regarding whether you might have an immunodeficiency or not is not sufficient. Even people who have allergic inflammation are at risk for having a functional immunodeficiency as well, because you have a barrier problem or a connective tissue issue. These are some of the observations that we've identified in our practice. Again, we've identified 15 patients with idiopathic CD4 lymphocytopenia, plethora of individuals with antibody deficiencies, from selective antibody deficiency to common variable immunodeficiency. I know this is more than you got in the 3 weeks of immunology way back when, but we also have identified individuals with a complement deficiency, and that's mannose-binding lectin. Matter of fact, 90 of them out of the 600 have mannose-binding lectin deficiency. And mannose is used to help recognize mold like aspergillus. So it's definitely more than just allergies when it comes to mast cell dysfunction. And again, a lot of these patients are really, because the testing is negative, or people are not looking at them or not listening to them, or they're getting their care from lots of different doctors who don't talk to each other, they get labeled. Matter of fact, there was a Medscape article last summer where it was a question posed by the board. You have a 48-year-old woman who comes to the emergency department in abdominal pain, all the tests from her primary care are completely normal. What's the diagnosis? A, conversion disorder. B, hypochondriasis. C, somatic disorder. D, malingering. And E was Munchausen, and the answer was Munchausen. Not what other tests should you get. You know, it was an automatic, and this is happening to the point now that they are taking children away from mothers. People are being inappropriately hospitalized and subjected to procedures that they don't need. That trauma alone, we have a 14-year-old who was forced to was physically restrained by 3 guards and to receive an NG tube to get force feeding because they felt that it was an eating disorder. It's a great way to address an eating disorder. So, unfortunately, delayed diagnosis happens because patients aren't aware that they have a connective tissue disorder, a mast cell issue, or a dysautonomia. General practitioners have very little education on this as well. And specialists sometimes are a little bit stuck in their ways. You know, if I hear and then the person had a normal tryptase, I'm like, okay, what's a normal tryptase? So just to give you, I'm going to finish off with this one case report. This is a woman that I had first came to my practice. I was allergist number 4 or 5. She had came to me with hives, and antihistamines weren't working. But she also complained. If you look at my questionnaire, there's 4 pages of just review of symptoms, and she checked every single organ system, including neuropsychiatric issues. And this was her blood test. So if you just look at the CBC with DIF, it's really unremarkable. And you can see that IgE is 9, so you wouldn't think a 9 would translate to allergen-specific IgE, but we went ahead and looked, and you can see even with that 9, she was making IgE to mold and animal dander and dust. And also, she was recruiting in complement. So something was telling her liver to produce complement. Then we went ahead and looked for more mast cell specific information, and interestingly enough, she made an antibody against her mast cells. She was hypogammaglobulinemic, and she had a history of getting antibiotics 3 to 4 times a year from different doctors who were involved in her care. So her diagnosis actually was common variable immunodeficiency, and we see this every day now. So she has mast cell activation disorder because she has a tryptase of 9, and according to Josh Milner, who was one of the lead authors of that alpha tryptase gene, she has a duplication of her tryptase. She also has autoantibodies against her mast cells. And she said, if you change my antihistamines again, I was like, let me just back up and be near the door just because I don't want to get hit. But actually, she came under control with, first we gave her prophylactic antibiotics along with tailored probiotics and colostrum. And when she broke through again, we put her on IVIG, and on IVIG, her hives went away. She was able to reduce her psychotropic medications. And she had not had another suicidal episode. So, really important again, this is the diagnosis. Do you have signs or symptoms? Do you get better with mast cell targeted medications, and what are your test results? And then from there, you really need to kind of target you need to figure out why your mast cells are misbehaving. And I'm going to stop here just to see if I can answer any questions. But I appreciate you inviting me down and taking the time to listen to my musings. And I'm delighted that it's going to be a collaborative effort, because it really does mean that we need to learn some new tricks to help these patients get better and screen before they really get worse. So, thank you.